I know that it is the evening for Algeria, Morocco, and Mauritania and France, but it is early in the morning in Japan. So thank you to all of you to be here for this first webinar of Algerian Society of Neurosurgery. And today we will talk about an interesting topic, which is Moyamoya, management of Moyamoya in adults and in children. And as president of the Algerian Society, I said to my dear guests, thank you so much for accepting the invitation in a very short time. And thank you also to the panelists, and thank you also to Professor Houari and Nabila Tirilt, who has done a very big job to organize this first webinar. So again, welcome to Professor Laurentines and Professor Katsumi Takizawa. And I will call Professor Bouyoussef to introduce our guests. Thank you so much.
Thank you very much. Hi, everybody. Nice to see you all. It's an honor for me to introduce the three speakers. First is Professor Laurentines from Besançon, France, French. He's the head of Department of Neurosurgery in Besançon, and he is also the president of French Cerebrovascular Society. He will speak about Moyamoya in adults. The second speaker is Professor Katsumi Takizawa from Japan. He is also head of Department of Neurosurgery in Asahikawa. Is like this. Red Cross Hospital in Hokkaido, Japan. He is also member of ACNS board. He will talk about Moyamoya in children. And the third speaker is Professor Lucif Houari from Algeria. He will present us two cases, one child and one adult. And welcome everybody, and I give the microphone to the Professor Tin to give his conference. Thank you.
Thank you very much for your invitation tonight. Can you see my
it's
slides?
Okay. Tines, it's okay.
It's okay, but it's not going to be that easy to go through the slide. I think. So you asked me to talk about Moyamoya disease and the surgical management in adults. So thank you very much for your kind invitation. So, excuse me, because I can't go through the slides. Don't know why.
It's okay.
Yeah. No. So as you can you see my slides there?
Yeah.
Yeah, it's okay.
Just to have a diaporama, please.
But I can't go through the diaporama. I don't know. So Moyamoya disease is a very rare entity. So you will see that I had kept my my slides in French because I know most of you are French-speaking people, and probably my English will be worse than my French, as you can see. And so Moyamoya disease is a very rare disease under in our countries, in France, and also in North Africa. This is a disease we will encounter mainly in Japan or Korea. It can be discovered in children with ischemic symptoms, In adults, most of the time, they are discovered through hemorrhagic complications. And what we know is that when you have a stroke from Moyamoya disease, which is defined as the occlusion of the carotid termination with the development of a strong network of deep arterial arteries that can sometimes bleed. When you had a stroke, a first stroke, you have a chance of 65% during the 5 following years of having a new stroke. So this is a very aggressive disease. And this is why in many instances it is mandatory to operate those patients to avoid new strokes. So I have to, I'm very sorry, but I have to go out of the diaporama because I can't push the slides.
Tines, Laurent,
Yes.
I think that you have to switch it off and restart.
Switch it what?
Yeah, switch everything and restart it. Close it and restart it. It will work.
Okay, it works. Yes, thank you. And one of the main points in my point of view while managing those patients is that you have to make a disciplinary decision on a very strong criterion to select the good patients for this kind of procedure. So most of the time you will treat only symptomatic patients. It is quite rare in my experience to operate on asymptomatic ones. And most of the time you will operate also patients that had recurrent stroke or a progressively worsening disease. And it is very important in this population to look at alteration of the brain perfusion, and particularly of decrease in cerebrovascular reserve. So you can use many testing to find out if the patients has impaired perfusion. You can use SPECT, you can use MRI, perfusion, and so on. And most of the time you will have to make, oh, sorry, again. You will have to, use some testing with Diamox to analyze the cerebrovascular reserve. And as you see here, the risk of recurrence of ischemic recurrence is about 10% per year, and the risk of a recurrence of hemorrhagic stroke is about 7% per year. So it's quite high, particularly if we are talking about young patients. So the objective of the treatment is to augment blood perfusion to reduce the risk of ischemia, but also to reduce the size and the number of those deep Moyamoya vessels that we know that can bleed over time. So you will aim, each time I touch the PowerPoint, it goes, it's painful. Okay. So I cannot show you anything on the slides. I'm sorry, but you will aim at the development of cortical neovascularization, or you will aim at directly, and this is the purpose of direct revascularization. You will look at augmenting directly cerebral blood flow by the use of a bypass. mortality of those procedures is quite low, about 5% morbidity and 1% mortality, provided you have a strong anesthetic management all over the procedure, keeping normocapnia, normoxia, and normal blood pressure. So this you will use indirect procedures, and you will be able also to use direct procedures. We go through those different type of surgeries. So when you want to do an indirect revascularization, you will use the tissues around the brain. That means the arteries of the scalp. You can also use the temporal muscle, or you can use the periosteum, as you can see on the right side. The main technique is called EDAS, but you can use also EMS when you use the muscle, or if you use the dura, the temporal artery, the muscle, you can do what we call an EDAS. This is what you can see on the upper picture. In children, but my colleague will talk about that. You can also use this technique in adults. You can do the multiple burr-holes technique. The advantages of those procedures is that they are quite simple to use, very efficient in children, and but the inconvenience in adults is that the appearance of those cortical PR vessels is quite uncertain, and you can see that in adults only 50% will actually develop cortical vessel coming from these procedures. So here you can see, I'm going to show you an EDAMS technique. Here you can see that we are preparing the temporal artery, and then you will have to prepare also a muscle flap, and then you're going to do your bone flap, open the dura. What is very important in all those procedures, whether we're talking about indirect or direct procedures, is that you have to open the arachnoid. And you can see here on this picture that under the scissors that the arachnoid is quite thick in those patients because of probably of inflammatory modifications. So here you can see almost the final picture where you can see the temporal artery, the muscle flap has been put under the dura, and at the end the dura will be closed, put directly on the brain, and then you have you can put back your bone flap with the usual technique and close the skin. So in some patients, adult patients, this technique might be quite effective. So you can see here this 30-year-old patient with this classical Moyamoya angiopathy with occlusion of the carotid termination. You can see here that there are no vessels, almost no vessels on the cortex. And here on the external artery, you see that there are some feeders that are coming from the middle meningeal arteries. And you have to pay attention when you harvest or open the dura, not to sacrifice arteries that are taking care of the brain. So here you can see the superficial temporal artery that's going to be harvested. So this is the middle meningeal artery that you have to save during your surgery. Otherwise, you might risk a very large stroke in the parietal region. And this is the post-operative follow-up, where you can see all those vessels on the front view. the frontal view, are those vessels coming from the superficial temporal artery and revascularizing the left hemisphere, as you can see here with these red arrows. Other technique, direct revascularization, which is actually my preferred technique in adults, I mean. The main objective is to perform a direct anastomosis between, usually you use the superficial temporal artery that you will connect to a cortical M4 vessel. So you will have to dissect this artery, do a temporary clipping under anticoagulation, and then you micro suture. The main advantage of the technique is that you obtain right after the surgery the good flow for the brain, and in most of the case you will have a very strong improvement of brain perfusion immediately after the surgery. The inconvenience is that it's quite tough in children, but maybe not. Our Japanese colleague will show us some cases of direct bypasses in children. And the other inconvenience is it's a technique that is longer than the classical indirect EDAS technique. So here you can see the beginning of the procedure where you mark your superficial temporal artery with a micro Doppler. Then you cut the skin under the microscope, harvest the temporal artery, do your bone flap as we have already seen. Then you will prepare the ends of the superficial temporal artery with this classical fish mouth opening. And then you will compare the size of your donor vessel with the size of your recipient vessel. And as you can see on the right hand side picture, the cortical artery has been prepared. The small cortical collaterals has been coagulated, then divided. And then you see this background, this blue-black background under the artery that will help you to do your suture in a few minutes. So then when everything is prepared, your temporal artery, your cortical artery, you just have to improve a little bit the blood pressure of your patient. Usually this is the time I push some 2,000, 3,000 heparin into the patient, and then do the clamping of temporary clipping of the receiving artery, as you can see here. You can color with a blue marker the surface of your artery. Is going to be easier than to do your macro suture. So you can see here we had performed this bypass using this artery. And here you can see a video of one of the last stitch. So you have to be very precise and very gentle with the arteries, particularly in Moyamoya patients. They have sometimes very, very bad arteries, very fragile, and you have to push very gently your needle through the artery. So usually before the last stitch, I remove the clip to flush the anastomosis site. So usually I use this 10-0 nylon suture with a smooth needle. I strongly not recommend to use the diamond needle because they actually cut the artery. So this is the end. I always keep the needle into the field in case you need to do a complementary suture. So here we remove the clipping, and there's no leakage. So when you have this situation, you're quite happy. This is almost the end of the procedure. Usually when you have some small bleeding like this, sometimes you just need to wait, but you always have to check. And if needed, you can add another stitch very prudently, because sometimes it can snooze your anastomosis site doing this last stitch. So you have to make sure it is very mandatory to do this. But in this case, I felt that there was a bad leakage at the suture. So you have to be very superficial when you do this stitch. You see, I do not clamp. I do not clamp the artery. I just pass the stitch like this. And then you have to use the forceps, and then you pass your last stitch very gently again. And then you do this superficial additional stitch to make sure that there is no leakage anymore. So then when this is done, usually I perform an angiography using the ICG with the microscope that shows you that your bypass is patent. So you can use the microdoppler also, or a debimeter. Now in Besançon, we have the Schaber probe that helps us to measure precisely the flow that you have given to the brain. So actually, when I said this was my preferred technique, it was not completely true, because my preferred technique is the combined revascularization. That means using a direct bypass with an indirect revascularization. So you have the direct anastomosis and also the encephalosynangiosis, using the muscle, using the periosteum, using the dura, and everything you can use actually to improve your delayed revascularization. So this is the post-op, one of my post-op follow-up. You can see here the bypass with the superficial temporal artery with this good revascularization of the MCA territory. And you can, usually I do SPECT perfusion post-op to make sure that this, like in this patient, the defect in blood perfusion has recovered. So when you go through the literature, you will see that in adults, the direct or combined technique are better than the only indirect technique using EDAS. As you can see here, the risk of stroke was 14% with EDAS alone, and it was 1.7% using direct bypass with EDAMS, so-called the combined revascularization technique. And it's been shown in Japan, in the US, that this direct revascularization was also very efficient. As you can see, they had in this series a reduction of stroke at 5 years from 65 to 5%. And also already in this paper, they showed that the hemorrhagic risk was also decreased by 3. So it was quite interesting. And then in 2014, our Japanese colleagues showed that in the adult population with that revealed the disease by bleeding, they were able to reduce, strongly reduce the risk of rebleeding almost by 6. So actually the direct revascularization technique in adults is, to me, the main technique that should be used to prevent rebleeding. So to conclude, this is a rare disease. you need multidisciplinary decision making. Most of the time in aggressive forms, you will have to perform any kind of revascularization. If you're not able, or you're not used to the direct technique, you just can use the classical Adams technique, which might be in some cases very efficient also in adults. But the main technique to me remains the combined technique using the Adams plus the direct revascularization. And as you can see here in this Japanese series, the risk of stroke after surgery was strongly lower than without any kind of surgery. So I really think those patients need surgery when they become symptomatic and when they have disturbance of blood-brain perfusion. And in adults, I would favor the combined technique for those patients. Thank you.
So thank you, Professor Tines, for this outstanding presentation. I think that we have to move to the second presentation of Takizawa.
Yes.
Professor Takizawa, please share your screen.
Yes. Can you see my presentation?
Yes.
Yeah,
Yeah.
everything is okay.
Okay. May I start my lecture?
Stop this. Yeah, it's okay.
Okay, may I start?
Yeah, you can start.
Okay. Hello, everyone. I'm Dr. Takizawa from Hokkaido, Japan. Firstly, I'd like to thank you again for giving me the chance to speak today. I'm very happy to be here. Also, I hope all Algerian colleagues are doing well in serious situations. Okay, today my topic is bypass surgery for child Moyamoya disease. Okay, as you know, this disease firstly described in 1957 as hypoplasia of the bilateral internal cultured arteries. Okay, the name of Moyamoya comes from the characteristic findings on angiogram, named by Professor Suzuki and Takaku, very famous legend neurosurgeon in Japan in 1969. Okay. Moyamoya is a Japanese word, okay, meaning puff of smoke. Okay. Angiogram findings looks like puff of smoke. Okay, so called Moyamoya. Okay. Now it's all over the country use Moyamoya. Okay. This disease is an uncommon etiology and high incidence in Eastern Asia countries, Japan, China, Korea. The essence of this disease is the spontaneous occlusion of the circle of wheels. Almost 2 times high incidence in female compared to a male patient. Around 10% familial occurrence. And annual incidence rate in Japan around 0.5 per 100,000 population. Okay. There are 2 peaks, child and adult. The main cause of the ischemic stroke in child. On the other hand, in adult, almost present with hemorrhagic stroke. Already, first presenter described. Until 2015, in Japan, to diagnose the Moyamoya, we should perform the angiogram. Okay, angiogram is essential. But now we can be diagnosed only by MRI, Moyamoya vessels and bilateral IC occlusion. Okay, also, until 2015, okay, unilateral type, we can't diagnose as Moyamoya disease. Okay, but Moyamoya is a progressing disease. Okay, so now we can be diagnosed as Moyamoya if it's a unilateral type. Okay, as you know, this disease is unknown etiology, so we cannot cure the disease itself. Okay, but bypass surgery is the only effective treatment to prevent further stroke. And this is a key stage classification, very famous stage classification. Okay, this stage indicates the so-called ICEC conversion, okay, named by Professor Miki Fujimura. Okay, it's a physiological compensation mechanism in Moyamoya patient. Okay, finally convert to the ECA supply. Okay, so the purpose of bypass surgery for Moyamoya is to create the ECIC conversion artificially. Okay, and this is a angiogram, ICAG and ECAG. Okay, after surgery, IC flow is decreasing gradually. On the other hand, ECA flow increasing. Okay, this is the artificial ICC conversion. This is also MR angiogram showing ECIC conversion. Okay, this is the purpose of bypass surgeries. The surgical indication for child Moyamoya is a ischemic event such as TIA or minor stroke, and impairment of CBF study such as PECT or perfusion or PET. Also, sometimes present with severe headache in child patient. Okay, after bypass surgery, okay, this headache is resolved. Okay, so severe headache is also surgical indication in child patient. Okay, surgical option, it can be classified into 3 categories: direct bypass, indirect bypass, and combined approach. Okay. Direct revascularization is slightly invasive and slightly difficult, especially in child cases, because of the vessel is very tiny and fragile. But the flow comes just after the surgery. Okay, very, very effective procedure. Okay, on the other hand, indirect revascularization is more easy and less invasive. But the flow is gradually developing, not earlier. It takes around several months. Okay, also sometimes ineffective, especially in adult patients. In this case is a 13 years old female girl. He was taken bilateral EDAS at the age of 5 at another institution. Okay, right side, you can see right side is developing good collateral flow. But left side, only limited area perfusion, can not effective so much. Okay, this is in direct revascularization. Also, almost bypass surgery may focus on the MCA territory, only MCA territory. So after the surgery, CBA flow in ACA territory is not improved. So in child patient, maybe lead in intellectual developing disorders. Okay, so especially in child patient, we should consider to perform revascularization to the ACA territory Okay. ACA territory revascularization is very important in child patient. Okay. Several also reported the revascularization to the ACA territories. Okay. So Professor Iyama from Japan firstly reported direct STA ACA bypass in 1998. Okay, so our procedure, so-called pan-synangiosis, is a combined approach. Okay, it means performs both revascularization, direct, indirect, to both territory, MCA and ACA. Okay, we perform all revascularization. This is one case is 4 years boy. This is a open video. This is a skin incision including both MCA branches. Now harvest MCA frontal branch. This is a gargle flap for the indirect bypass to the ACA territories. To perform ACA direct bypass, we should harvest frontal branch of STA as much as possible. Okay, very tiny. Okay, this is the frontal branch. Make a two-piece craniotomy for ACA and MCA. Now cut the dura. We should preserve middle meningeal arteries. Very, very important. Also, dura use indirect bypass. Inverted the outside of the craniotomies. Now performs STA direct bypass. Usually use a frontal branch of STA. Okay, now make a trimming of the end of the STAs. Make a fish mouth trimmings. While that is very useful for better visualizations. They usually use 11-0 nylon sutures. I prefer use both sides forceps, not needle holder. Okay, now finish the bypass. Then performs STMCA direct bypass. Okay, you can see the working well, the bypass. This case it performs triple anastomosis. This is a direct ACA bypass. This is indirect gargle flap and muscle flap. Then closure, cosmetic closure using bone tips and temporal muscle fascia. This is the original pan-synangiosis devised by my mentor, Dr. Kamiyama. Okay, after surgery, you can see the good developing of the collateral pathways, also improving the CBF. Also, this case is improves the IQ also. And this is our result of this procedure. Around 10 years, 17 child, 22 hemisphere. Mean age is 82 years, almost present with ischemic event. Okay, no mortality and no morbidity. Okay, post-operatively, no ischemic event. Also, all most cases improve the symptoms. But the main trouble is ischemic skin troubles, around 20%. This is the most important problems, these procedures. For example, this is a 4 years girls. This is a 6 years later, but very, very stable skin trouble. Also, this case is 3 years old boys also make big alopecia. This is no good. So also this closure is very complicated. So later the occur the cosmetic problems like this. So now I modified this procedure. For example, don't take a gallial flaps for ACA territory in direct bypass. Okay, now we use a pericranial flap. Okay, also this flap connects to the muscle, temporal muscle. Can make a wider, big vascularized flap. They cover the, both ACA and MCA territory together. Also, now I perform the one-piece craniotomy, not two pieces. So this is after direct ACA MCA bypass, and this is after indirect revascularization, covers the pericranial muscle pellicles. Very nice, covers widely. Also now close only minimum use of absorbable plate, just 3, very simple. It's good for the infection or a cosmetic problem. So another tips for the surgeries, now no need to cut the hairs. Also put head clamp onto midline, okay, because never damage the ECA branch, such as STA or occipital artery, not one side, both sides. Very, very important for the Moyamoya patient. Also, we can diagnose Moyamoya only MRI, but in surgical case, we should check angiogram before surgery, okay, because the already developing the collateral pathway from the ECA branches. This case is spontaneous collateral flow already developing from the middle meningeal artery. Okay, so we never damage this collateral. Okay, so this case is only make a craniotomy this territory, no need widely. Okay, like this. Okay, this is after surgery, creates a good collateral flow. Also, this is another cases. 10 years boys already developing spontaneous collateral flow from the ECA, anterior part and occipital part. Okay, so this case is we should consider the revascularization only these territories. Okay, so I perform small craniotomy and make a combined approach. Now developing a good collateral. Okay, the check the angiogram before surgery is very, very important. Also, how to select the recipient arteries. Okay, preservation of the MMA also very important. Now you can see the two vessels, this one and this one. Okay, this one looks much bigger, but more reddish. Okay, this one is slightly small size, but the color is whitish. Okay. Okay, this one is better. Okay, reddish one is original is very, very small. Okay, now is maximally dilatation. So vessel wall is very thin and fragile. Okay, so if you can see the like vessels, this one is good, better for the recipient arteries. Again, I'd like to show STA bypass techniques. They harvest both branches of the STA, like this. And this is a recipient arteries. This is a trimming of the STA. Okay, take off the connective tissue from the end. Okay, now make a fish mouth trimmings. And put a violet dye. Okay, it's very useful for better visualization, especially in tiny vessels. Firstly, put both end, here and two, only recipient. Then put the temporary clips, confirm the complete occlusions, straight line cut. Okay, firstly, perform both stays sutures. This case is also use 11-0 nylon sutures. The vessel is very fragile. Okay, never give excessive tension. Okay, move slowly, gently. Okay, no need to hurry up. Okay, don't bite far from the edge of the vessels. For bypass surgeries, the preparation of the surgical field, okay, meticulous hemostasis, take away the recoils is very important. Okay. Also, we can perform the, all kinds of hold the needles. Now is the backhand holding. And now is straight holding. To perform the under high magnification microscope. Okay, before open the temporary clip, block the end of the STA is important. Okay, if we don't block here, reverse the flow into the STA. Okay, if make some trouble, it's a risk of a thrombosis formation. Okay, now open the arteries. You can see the good patency by ICG. Okay, this is a direct STA bypass technique. Okay, conclusions. Bypass surgery is the only effective treatment to prevent further stroke. Okay, we should consider the revascularization, not only MCA territory, but also ACA territory, especially in child cases. A combined approach is also useful and effective in child Moyamoya disease. Thank you for your attention.
And thank you, Professor Takizawa, for this presentation, for this very good presentation. So I think that I will follow with my presentation, and after that we will ask questions.
Okay.
Do you see my screen?
Yes.
Yes.
Okay, so for this topic of Moyamoya, I knew that every one of us will show us all the techniques, bypasses, direct and direct combined, and this is why I thought to make something special. I think to put something more interactive. This is why I bring with me just two cases, one adult and one in childhood. So I will address my first case to Professor Tines and the second one for Takizawa. This is patient that uh, this is cases that everyone will question about how this decision making. Okay, so the first before starting, I would like to thank everyone who has worked on to make this event happen, and all the panels. And also to Dr. Sheikh, who give us the opportunity to contact Professor Takizawa. So in our department, in my previous department in Bedwood Hospital, I was working with Professor Morsli, who is in the panel. So we operated 15 patients, 7 adult and 8 children. We made everything direct combined, PL synergiosis, and you know, I'm not here to show you the technique because we have seen everything just before in the two presentations. So the first case is for Professor Tines, because he presented for adults. So the first patient is a woman of 50 years old. With I saw her in consultation. So she had 3 years ago hemiparesia, and when I saw her, she recovered from her deficit. She had just dysarthria. So the imaging shows on flare these sequences like you see an ancient and old stroke on the MRI. So the angiography shows, sorry. So the angiography shows, like you see here, there is we can see the middle cerebral artery, and we see a small network of Moyamoya here. But we see pretty good well here our carotid. So the question is it Moyamoya? Is this network seems for you being a Moyamoya? Because you know the definition is Moyamoya is the occlusion, the stenosis of the carotid. The carotid looks like good. So this is the first question. And after that, we have done perfusion on CT scan. Like you see here, we have the flow, and we took at the margin of the stroke. We took 2 rows. As you see at the right and the left, it's 55 and 31. Also with the MT, the CBV, like you see here with the volume, it's like averaging the half. And the second question, is there a mismatch here? Like you see here in this image, is there a mismatch? And how far can we tolerate a mismatch? So what to do? Professor Tines, I ask you this question for you. Please, would you please share with us your experience?
Well, the cases you shown is not a classical Moyamoya case because, as you said, you don't have this complete occlusion of the carotid termination. in Europe, and I remember when I was in Lille, we had a couple of patients coming from North Africa that had this kind of occlusion of the middle cerebral artery. We call that Moyamoya-like angiopathy. I think we should better talk about Moyamoya angiopathy rather than Moyamoya disease, because Moyamoya angiopathy can be seen in many other situations. The case that you have shown is an example. And but the physiopathology of the disease is similar to Moyamoya disease, actually. And we have also to differentiate Moyamoya disease from Moyamoya syndrome, which is a secondary occurrence of the occlusion of the carotid termination, either due to radiotherapy and other disease, genetic origin, etc., etc. So in your case, I would not call that Moyamoya disease, but it might be a Moyamoya angiopathy, although the collateral deep vessels are not very large. But yes, depending, I haven't seen clearly the angiography actually, but
yeah, I can show
it seems that there are some kind of deep vessels. They are not very large, but as you can see, the MCA is occluded, and then you can see also that there are other indirect angiographic features that could lead to the diagnosis of Moyamoya angiopathy. Is the development of corticopial collaterals from the ACA, as you can see in the frontal view. And then you can see also collaterals from the pericallosal arteries. So they might have some kind of corticopial collaterals. And as you've shown on the perfusion examination, I think there was hypoperfusion. I don't know if you performed the Dymox testing in this case, or just is it CT perfusion?
Yeah, it's a CT perfusion. We see here the hypoperfusion, and we, as I said, we took just 2 ROIs to compare between the 2 hemispheres. So what we do in this situation, Professor Tines?
It really depends. And you don't, because this patient had a stroke on the left side, right? Also, it was an old stroke.
An old stroke. Because she made her hemiparesis 3 years ago. When I saw her, she recovered very well, and she was stable.
And what about the left carotid? How was it?
It's okay.
It was normal.
Left carotid is okay.
And
but here, as you see, there is lesions. There is a spot here of, I think, hypoperfusion on
location.
Yeah, in the transitional areas.
Yeah. And
so
usually,
what we have to do in this situation, Professor Tines, because do we have to operate in the other side because we are afraid? We see on these images that there is this side also is there are spots which are hypoperfused. Preventive surgery for this side, even if the carotid is good, doing something in this in the side of the stroke, or just following her with the exams?
Actually, it's a situation that is quite frequent. Yeah, I mean, you see a patient that had an old stroke, and it's not that easy to make decision in this case. If you tell me that she had an old stroke on the left side, and if the left ICA is not is normal, although there is hypoperfusion, I'm not sure I will go on the left side. And for the right side, she had this MCA occlusion, but then she did not have a stroke on the right side.
Mm-hmm. Yeah.
So usually I do not perform revascularization if the patient is asymptomatic, unless he has some kind of transient stroke or very, very bad perfusion with impaired cerebrovascular reserve. But in this case, as you haven't done any Diamox challenge, it's difficult to tell if she has or not cerebrovascular reserve. So maybe I would follow this lady for a couple of months or year and see if she gets symptomatic before going to surgery.
This is what we have done with all the team of Babel, with Professor Mosley and Professor Habouchi, who are in the panel. We discussed this case, and because the patient was stable, we said that we have to follow her, and we perhaps redo exams if there is a new clinical sign. So thank you, Professor Tines. Now I will move to Professor.
Can I do a remark?
Sorry.
Can I put just one remark on the
sure,
imaging?
Sure.
As you can see here.
Sorry, Professor Habouchi, I will introduce you. Professor Habouchi is a neuroradiologist. We work together for all the neurovascular patients.
Thank you, Lucif. It's a very interesting case, because what we can see here on the perfusion is that we have a decreasing in the cerebral volume and flow, but we don't have a mismatch with the diffusion images and also with the MTT. So in these cases, and as you can see, the stroke is not on the junctional zone of the brain. So it's not a stroke has been done because of a high hypoperfusion. In these cases, it is, I think, our decision to control the patient was good. I'll let you just move on with the follow-up of this patient. Thank you, Lucif.
Okay, so we'll move to the second one for Professor Takizawa.
Yes.
The patient I received this week, this patient aged of 7 months, with he had an hemiparesia since 2 months. It means that he had 5 months when the event came. So this is the images. As you see on diffusion, we have almost all the hemisphere. And as you said in your presentation, we can do diagnosis of Moyamoya on the MRI. Like you see here, there is a network on this side. So, and when we have done the reconstruction, as you see, there is a we can't see the carotid. There is no carotid termination here, and the problem also is the basilar trunk. There is a stenosis in the basilar trunk in an infant of 7 months old, and the posterior circulation is fed just with a PCOM. So what do you think about it?
Oh, you mean how to treat this case?
Yeah, what do you think about it? Do you think that because there is carotid occlusion, there is a problem in the carotid, there is a problem in the basilar trunk? What in your daily practice, how do you deal with these problems?
Oh, I think this case is Moyamoya disease
Okay.
because I don't think another disease, but very, very young. Okay. Also, this disease is a progressing disease. Okay. So now is just observation or give a antiplatelet, then check again the MRI. If occurs another symptoms, maybe consider to perform indirect bypass. But for the posterior circulation territory, actually say very, very difficult.
Yeah, this is the question. This is
No.
how do you deal with the posterior circulation moya occlusions in an infant of 70 months old? So it's an indirect for all the hemisphere.
Actually, say in adult cases, there are many procedures. STA PCA bypass or STA SCA bypass. Okay, you can treat direct revascularization surgery, but this case is very, very small.
Yeah.
So now is maybe impossible.
Yeah. But the baby is still having strokes.
My youngest case is 11 months baby.
Okay.
Okay, for direct STA MCA bypass.
Wow.
But no experience revascularization for the posterior circulations.
Okay. Thank you,
So
Professor Takizawa.
if we can wait more, around 2 or 3 years, maybe possible direct bypass.
Thank you,
if we need this case.
Thank you. Thank you. I finished with my presentation. Professor Bouyoussef, are you here? The members of the panel, Professor Bouyoussef, Professor Morsley, Professor Boutlilis, Professor Bakhti.
Voilà, c'est bon.
Professor Tina, if you want to add something for the pediatric case.
I would, in this last case, I would just ask to our Japanese colleague if he would recommend only indirect revascularization because the patient is symptomatic. He has done a huge stroke.
Yeah.
Does he think that indirect revascularization is feasible at this age?
Which side? Both sides? You mean?
On the left side.
Only left side.
Yeah. Do you think we could do that at this age? It would be efficient.
Yeah, I agree.
Maybe with the burr technique.
Do you have some plan for the posterior circulation territory?
Do I have what? Sorry. What do you want to see?
I asked to Professor Tines.
Yes.
Yeah. Do you have some plan or procedure to the posterior circulations?
No, I've never done revascularization on the posterior circulation, but maybe with the burr technique we would be able. I think the basilar occlusion increase or decrease the blood perfusion, because usually in Moyamoya patient the basilar trunk is preserved for a long time. It's very rare that they have posterior circulation occlusion. So usually it's a stage where they become symptomatic again, and that worsen the disease actually. But maybe making burr holes at the back of the skull might help this patient to develop quickly collaterals from the meningia, maybe. I don't know.
Thank you.
Professor Abu Youssef.
Just to comment, I think that all the angiopathies of the brain are not Moyamoya.
No.
I think that we have to think about all the other etiologies of Moyamoya. Drepanocytosis, after irradiation, neurofibromatosis. This is very important for the young people to know that all arteriopathies are not.
Of course.
The question is, how long time do you perform left and right side before or how long time do you perform the second vascularization?
The Professor
Do you
Youssef,
understand me?
do you ask the question for
everybody?
For everybody. Professor Tinas, what do you think? If you have to do vascularization in both sides.
Okay. So usually I start on the most symptomatic side, either the side where the patient had symptoms, or if the patient doesn't have symptoms, on the side that has the worst cerebrovascular perfusion. And usually I wait 2-3 months after the last stroke, because when the patient had a stroke, he's at a higher risk of postoperative complications like hemorrhage or postoperative stroke. And then I would wait. Usually I wait 2 or 3 months after the first side. So if I start on the right side, let's say, I would wait 2-3 months before going to the other side to let the patient recover from the first surgery. And sometimes you will have the good such a good result on one side that might modify the vascularization, the blood flow of the whole brain. And it happens in one of my case when I did the right side, and when you do the SPECT post-op, the whole brain is improving because of the circle of Willis. You can have some flow that is redistributed to the other side also. So when you do one side, I would wait, do a SPECT before going to the other side.
Please, Professor Morsley, excuse me, Professor Youssef. Excuse me. You want to add a question?
Yes, please.
Yes.
When you have a hemorrhage, when you have hemorrhage and you have aneurysm, you put the clip, and do you perform in the same time the revascularization?
Well, you're talking about a Moyamoya patient with an aneurysm?
Yeah.
But
with aneurysm, yes.
Yeah. deep seated.
Yes.
Yeah. I had a patient from Saint-Etienne that was referred to our center last year. And I think he was about 40-year-old, quite young. He had a deep hemorrhage from a perforating vessel, and he had a very tiny pseudoaneurysm on the perforating artery. And actually, we go to a direct or combined revascularization, and it was so efficient that the Moyamoya vessel retract, and the aneurysm disappeared without doing anything on the aneurysm. So because usually those small perforators are taking care of the internal capsule, and it's quite challenging to occlude directly those small aneurysms. So I would do the bypass, wait a couple of months, and check if the aneurysm is still there, because you will see that in 2/3 of the cases, the aneurysm will be gone. What do you think, Dr. Takizawa? Have you experienced this?
Yes, my experience can treat by endovascular occlusion. Okay, comes the hemorrhagic strokes. So this is Moyamoya combined with small aneurysm. That case can treat by endovascular. So I don't recommend all cases direct approach to the aneurysm, because split the fissure is very difficult, almost impossible, because of the Moyamoya vessels. So another, if endovascular treatment is impossible, I agree your strategy. Just to perform the combined approach revascularization. Some cases disappeared after bypass surgery. I think so.
That was exactly the situation. The endovascular guys in Saint-Etienne tried to occlude endovascularly the aneurysm, but it was so tiny, the arteries were so tiny that they could not go through the perforating artery. So we just did the bypass, and it worked well. And the Moya vessels disappeared, actually, and the aneurysm was gone after 6 months. And we did not have to go directly to the aneurysm.
So, Professor Morsley, please.
Okay. Hello.
Have a comment or?
My simple question is, what is your experience, Mr. Tinas, for the sample surgery, method of Burhol?
Mm-hmm.
Do you have you an experience in this method?
Mm-hmm.
And in the department who this surgery is not practiced, the sample technique of Burhol, it is the first method in this department.
So
and what
I think, as I said in my presentation, I think that patients with Moyamoya that are symptomatic or that have very bad perfusion should be operated. But you have to do the technique that you know. So I think in the children, the indirect technique is the easiest. And in the children, the multiple Burholes technique is very simple to do and very efficient most of the times. In adults, it's a bit different because you only have 40–50% of the patients that will develop synangiosis and corticopial vessels. So it's less effective in adults, the indirect technique. But I think if you have a patient in your institution, it's better to do indirect than nothing. So I think the multiple burr-hole technique might be effective, but you have to really open the arachnoid in front of each burr hole. Huh? So it's very important to do at least 9-10 burr holes on each side. So usually I do this coronal incision, and then you do burr hole on the whole brain, and then open the dura, open the arachnoid, and then you put a small flap of periosteum into the burr hole, and might be effective, but the problem in adults, it's quite uncertain.
So, Professor Tinas, I think that we have to study the angiogram before, because meningeal arteries can feed this hemisphere, and when we do our burr holes and open the dura, we can coagulate or cut this, and the patient will have a deficit.
Yeah, of course. As Dr. Takizawa showed earlier, you have to look at the ECA very precisely, because sometimes the patients have very strong collaterals from the meningeal arteries, and it is forbidden to cut those vessels. And yeah. So you have to put your burr hole. You might use the neuronavigation if you want to put your burr holes at safe spots. You can use the navigation to choose the position of your burr holes if you have strong collaterals from the meningeal. If you don't have collaterals, you just put your burr holes where you want.
So, Professor Habushi, please, could you make a comment or?
Okay, I would like first to thank both of the intervenants, a very high level of presentation and lecture. And I have a question for both of you. First of all, how and at what rate do you control your patient? Do you control your patient by angiography, MRI, SPECT? And the second question is, did you meet or did you have in your patients hyperflow, hyperperfusion syndrome after surgery? Thank you.
Dr. Takizawa, you want to answer maybe?
I'm sorry, I can't hear the first questions.
The first question is, how do you control your patient after surgery? And at what rate do you control your patient after surgery?
Okay.
Do you prefer MRI, angioscan, angiography? It was my question.
Oh, okay. After surgery, in my hospital, the patient come back to the general ward, not ICU. Okay, and just control the blood pressure and give a anti-epileptic agent. So check MRI just after the surgery and day 1 and day 7. Also check the SPECT, maybe day 2 or 3. If we can detect the hyperperfusion, more down the blood pressure, continue around 1 week. Then check again the SPECT. Usually, we don't use an antiplatelet agent for the Moyamoya patient. That's enough, especially in the child cases also.
Okay, Professor Tinas, what do you think?
Well, usually my protocol is to perform CTA the first day post-op. Usually I like to do the angiography before the patient is sent home, because I want to know what I have done, because on the delayed angio, you might have different images, and you won't understand what happened actually. I don't do any MRI testing unless the patient has a deficit, maybe postoperatively he has deficit, he will have the MRI, but not on a regular basis. And then I will perform usually the second angio 6 months after the surgery to see if the bypass is still alive, and if the patient developed collateral vessels from the external artery. And at the same time, around 6 months, I do the SPECT perfusion with Diamox to check for the perfusion and the cerebrovascular reserve. And then usually I follow them 1 year, but I don't do any other angiography unless the patient has a new stroke, for example, and then I follow them with MRI to see if they do new stroke, and SPECT every year for a couple of years. And usually it depends on the clinical course of the patient. And for the second question that was about hyperperfusion, I had some cases that had hyperperfusion or disturbed perfusion. And I've seen that in many patients you revascularize on the left side, you often have aphasia, I mean speech disturbance, and so most of the time it durates a few days or a few weeks, and in most of them you don't find any stroke. It might just be a temporary situation of flow, of disturbed flow in the post-op. In one of my patients, there was a lady that had high blood pressure after surgery. She had some hyperperfusion and bleeding around the surgical site, and I had to reoperate on this lady. She had a subdural because of that, and it's not easy to reoperate after the bypass. If you have a bleeding at the surgical site, it's quite challenging. But we had to reoperate this lady, and she was fine after that.
Thank you for.
Thank you. Professor Khamlishi, do you want a medical mind, please? Are you here? I think he's not here. I see his name, but Professor Lakhdar. We don't hear you. Yes.
Thank you for this presentations. Really, we don't have experience in Moyamoya disease. We don't have cases of Moyamoya disease. So we learned today about many aspects about this pathology in children and in adulthood. Thank you.
As I said, when I was in Lille, we had a couple of patients coming from North Africa. So I think you have in your region Moyamoya patients, but they are underdiagnosed, I think.
Professor Tinas, I'd like to emphasize that I received a few mails from Tunisia and from Morocco, searching for management of their patient of Moyamoya.
Yeah, underdiagnosed, so perhaps a few cases underdiagnosed.
Is anyone from the panelists want to add a comment or questions? Professor Youssef, I see you.
Yes, thank you. 30 years ago, Professor Khamlishi have had a study. At this moment, we say there is no more aneurysm in North Africa. When he does his study in aneurysms in Africa, today we have the same rate in North Africa for aneurysm, and I think that we have the same rate for Moyamoya disease. We have to discover more and more this pathology. About the control, I think that in our experience, when we want to do a new indication for arachnoid cysts, we perform surround the cyst the ASL, the arterial spin labeling. This is a very good for perfusion, so to see the perfusion of the brain. I think that we can use it in this case when we want to perform after surgery, if the perfusion is good or not. It's a very simple exam. We can do it with the MRI, and I think that is placed in the follow-up for this pathology.
Of course, you're right. Thank you for this comment, because in children, particularly, the A cell is very effective because it's a fast sequence. And unless you do that under general anesthesia in young patients, the other techniques are not that easy to use. So I think in Necker, Paris, they use the A cell technique for Moyamoya.
Yes.
And we use it recently. Recently, I operated on a young children, and we did the A cell technique with the MRI, of course.
Thank you.
I think that Professor Kliba wants to make a comment. Suhail, where are you? He's not here?
I'm here. Thank you for this lecture. Thank you very much. I don't have any comment.
You don't have any comment? Okay.
It's okay for me. It's okay.
Mostly, would you want to add something, please?
Thank you for Mr. Tennis, Mr. Takatsumi, Huari particularly, and other panel, our great neurosurgeon, Mr. Bouyusuf, and for you, Suad and Nabila for this webinar. Very instructive topic. Thank you.
Thank you. I think
there is a question from
yes, please. Okay,
it's from Abdurrahman Sheikh.
Yeah.
So is there any technical consideration to take into account while performing anastomosis and handling the vessel in Moya patients compared with stroke patients or other disorders that necessitate anastomosis?
Is there any difference, you mean?
Is there any technical consideration to take into account while performing anastomosis and handling the vessel in Moya patients compared with stroke patients or other disorders that necessitate anastomosis?
I think Moyamoya patients are the most difficult anastomosis you can do, because as our Japanese colleague said, the vessels are diseased, so they are very small, very fragile, and the anastomosis technique itself is quite challenging. On the contrary, in patients with, giant aneurysms or carotid occlusion disease, the arteries are more normal, and they are easier to handle. And I would recommend to start on the carotid occlusion cases, to start the ECIC bypass technique, because the arteries are very large usually, and the arterial wall is stronger and easier to handle and to make your suture. And then when you are able to do that in those cases, you can go to the Moyamoya cases that are more challenging.
Okay, I have a question, Professor Tina, sorry. We operated on a patient of 35 years old with Moyamoya. We have done STA-MCA bypass, which was feeling the patent very well. We have done a CTA at 3 months, it was working. So 6 months after, the patient was when we have done the exam at the six months, there is no bypass. I mean, it wasn't patent. We have like these cases, but the patient was well.
Yeah, that does not surprises me actually, because in our series we've shown that usually the bypass flow decrease is around 5 to 6 months to about 50 cc's, and in some cases you will see the bypass vanish over time, for the only reason that the patient will develop collateral vessels, so the bypass will decrease because of that actually. So and the fact that your patient did not have any new stroke is the proof of that mechanism. So I think we don't have to be sad that the bypass is gone if the patient is doesn't have any new stroke. Actually, it's the indirect revascularization that take the blood flow, and the bypass is not needed anymore.
This is why I think it is important to do the combined one.
Yeah, that's the reason. Exactly. That's why it is my preferred technique for this disease, because then you have the addition of the direct revascularization, and then over time you have the indirect technique that take over the blood perfusion, and in this situation you have a more efficient bypass over time.
Okay, thank you.
So,
sorry, there is another question.
Nabila, there is another question, please.
Also from Abdurrahman Sheikh. So he's asking, what's the optimal permissible time for occlusion of the recipient vessel while performing anastomosis? Do you want me to repeat? No?
Yeah, I understood. There's no clear range of time. Actually, you have on M4 branches, you have the time you need to do your suture anyway. When you have opened the vessel, you have to finish the suture. So, and you will see that if you go through the literature, usually the clamping time is about 60 minutes. So I think you can close your artery for 30-40 minutes without any stroke.
So I
So
think
in my experience, usually it depends on the quality of the recipient vessel, but the average clamping time in my experience is about 20 to 40 minutes usually, not more. But if you look at the literature, it's around 60 minutes, and the patients usually don't have any stroke after that clamping time.
Do you
Professor
have
Takizawa?
Professor Takizawa?
I'm here.
Yeah, you agree?
Yes, so I totally agree, Professor Tines.
Okay, thank you. There's no other questions, Nabila?
Professor Youssef, you want to ask a question?
Yes, yes, please.
Raise his hand.
Sorry, I take the. Sorry? Ah.
Oui, oui. Vous avez demandé la parole.
I take the microphone many times, but before concluding, I would like to ask the young neurosurgeon that the bypass is a micro neurosurgery, is a neurosurgery. Is easy for you. You have to train, only to train, to go to laboratory, anatomic laboratory, you have to train. And also to tell once more that vascular neurosurgery, surgery of aneurysm, is micro neurosurgery. Don't leave your field to other specialties. This is my
endovascular.
Habouchi, tu réponds.
So I've been.
Vous m'avez compris.
Yeah. I've been in
Général de Gaulle,
the.
je vous ai compris.
I've been in the department of Professor Tines many times to see him operating and doing bypasses. So I think that if a young neurosurgeon wants to go there, what do you think, Professor Tines?
Yeah, each year we are organizing the bypass course in my department, and we've trained 5 young neurosurgeons every year. So we're quite happy if people can join this course.
Program.
So I might send you the invitations for the next sessions.
Okay. Thank you.
Okay.
I am
Sahli,
the
please,
youngest
last
neurosurgeon.
question. Excuse me, Professor. I didn't.
Vascular neurosurgery is not dead.
Sorry?
Sahli, last question from Dr. Sahli.
Thank you for our guest, and as many neurosurgeons in Algeria know that with Professor Houari we are working about developing a program about microsurgery and bypasses on death animal models. So I would like to ask Professor Tines and Professor Katsumi what is there any experiences in this way, or how about the use of such models in training of resident of trainees? Thanks.
How to train the bypass technique? In Japan, we have a artificial vessels for the training. So usually don't use small animals such as rat or mouse. Very simple, and we can train anytime. No need laboratory. Very, very useful.
So you can also train on chicken wings.
Yeah.
Sometimes use chicken wings. Yeah.
Oui.
How about the learning curve with using such models?
In my experience, I did my training on rats. I have to acknowledge that, but I mean, you need to do at least, I would say, 30 to 50 cases to be confident in your technique, and then to go to patients. But I agree, now we should train maybe on artificial models or chicken wings or things like that, and practice in the lab with these techniques.
And travel to
I think it was the last question. So we will conclude to say thank you to our guests for these outstanding talks, and thank you for Professor Tines to be awake at, it's near 12 o'clock in Paris. And thank you so much to Professor Katsumi to be awake at 4 o'clock in Japan. Thank you so much for that. And I want also to say thank you to our panelists, Professor Bouyoussef, Professor Morsley, Professor Habushi, who are experts with Professor Houari in this field in Algeria now. And also thank you to all the participants. I want to say that we have had participants from Pakistan, Sweden, Russia, Morocco, Mauritania, France, and of course, Algeria. And this was the first webinar. Thank you to be with us. I hope that we will have more webinars in the future in other fields. And thank you also to Professor Sheikh, to Dr. Sheikh, who is with us, because he helps a lot the Algerian Society for organizing this webinar. And that's I have to say to you. And good night and good day to Professor Katsumi in Japan. Thank you to all of you.
Thank you very much for the invitation.
Thank you. Bye-bye.
Ciao.
Bye. Arigato.
Bravo.
Au revoir, Monsieur Aït Ben Ali.
Au revoir.
Au revoir. De rien.
Kirax Said.
Thank you, Professor.